Okay, we've covered the two big bleeding disorders, von Willebrand disease and hemophilias A and B. But plot twist, the inherited coagulopathies aren't actually the biggies when it comes to number of people affected. Acquired coagulopathies, such as disseminated intravascular coagulation and vitamin K deficiency, are much more prevalent, affecting millions of people around the world each year. Let's get started with the true biggie: disseminated intravascular coagulation, abbreviated DIC, represented in this scene by a roll of the DIC dice. Ah, yeah, get that crit. You gotta get that crit. Sorry. Actually, we're getting a little ahead of ourselves here. You can't just jump right into D&D. Don't worry though. I'll take you through it, step by step. Starting with the most fun part, creating your character. Next step, coming up with an intricate backstory. And in this scene, we're featuring the story of disseminated intravascular coagulation. DIC is one of, if not the worst, forms of acquired coagulopathy. Normal coagulation is a protective mechanism with lots of negative feedback systems built in. Because, well, the consequences of clotting gone haywire are catastrophic. It's a precisely balanced scale. More procoagulant factors leads to coagulation. More anticoagulants, well, you know how the scale works. DIC, on the other hand, is sort of like putting so much weight on both sides that the scale just breaks. DIC involves exaggerated activation of both the coagulation and fibrinolytic systems simultaneously. That means excessive clotting and bleeding. See the board? Not only are there thrombotic trees gunking up those vascular rivers, we've included a hemorrhagic drink spilling across the table. It's weird, I know. You're new to this game. The most frequently encountered version of DIC is the acute type. And by acute, we mean that DIC starts with sudden activation of the coagulation cascade after an exposure to some kind of procoagulant substance. Gram-negative sepsis and infection, especially by Neisseria meningitidis, are the most common causes of DIC, in which bacterial proteins and lipopolysaccharides activate coagulation through a variety of complex mechanisms. This is symbolized by the discard pile for the dead game pieces, the septic pile. We even incorporated a gram-negative bacterial design into the border. Inside, notice that we've thrown in a few of those thrombotic tree pieces as well. Remember, we're promoting clot formation here. In reality, a variety of organisms can precipitate DIC, including fungi, viruses, and parasites. For the other causes of acute DIC, keep hypercoagulable conditions in mind. This includes malignancy, especially acute promyelocytic leukemia, trauma, obstetric complications, all kinds of stuff. DIC is almost always seen in patients who are already critically ill. Think ICU level sick. To make things even worse, critically ill patients often also have concomitant acidosis and hypothermia, conditions that further disable clotting factors and contribute to the bleeding seen in DIC. We've been focusing on hypercoagulation states, though. So why all the bleeding? Well, previously, in Sketchy Farm, we represented clotting factors with clotting fighters, all working together with the common objective of controlling that bleeding process. In this scene, the coagulation fighters are the game pieces, and they're tumbling off the board to evoke an image of a consumptive coagulopathy. DIC involves an initial coagulation cascade overdrive, resulting in the depletion of essentially every coagulation component, both pro and anticoagulant. Lots of clotting means lots of platelet plugs forming as well. So down go those platelets, as depicted by these discarded plates. As DIC progresses, the consumption of platelets, clotting factors, and anticoagulants outpaces their production. This leads to the interesting scenario in which both bleeding and thrombosis are a constant risk. Bleeding is the more common manifestation, so let's start there. Since all components of the coagulation cascade are depleted, the pattern of bleeding is consistent with both platelet-type bleeding and coagulopathy-type bleeding. For platelet-type bleeding, think back to von Willebrand disease, the last time our platelets were non-functional. This means you'll see petechiae, ecmoses, mucocutaneous bleeding, and characteristic oozing from almost everywhere in the body, especially around IVs or arterial lines. Or, in the case of this orc on the cover here, bleeding from spear entry points. In more severe cases, you'll also see life-threatening spontaneous GI, genitourinary, or cerebral hemorrhages, which is more of a coagulopathy-type bleeding, due to all of those missing factors. As a reminder, it's not just the procoagulant factors that are depleted. Protein C, S, and antithrombin are consumed too, effectively crippling fibrinolysis, a process normally responsible for keeping this whole clotting thing in check. Thromboembolic symptoms are less common, especially in acute DIC. But when it happens, thrombosis can occur in the venous or arterial systems. This includes venous thrombi, such as DVTs, classically in the iliofemoral venous system, with or without pulmonary emboli. On the arterial side, be wary of thrombi leading to tissue and organ infarction, embodied by the ominous necrotic-looking, what is that? Some kind of skull lagoon? So, yeah, lots of clotting and bleeding and revisionist medieval role-playing. How does this all show up on labs? First, massive consumption of coagulation factors will affect both the intrinsic and extrinsic pathways, prolonging PT and APTT, represented here by our recurring PT paratrooper, as well as that sound effect accentuating the thrilling action happening on the board. Secondly, platelet consumption leads to thrombocytopenia and a prolonged bleeding time. Man, I remember spending hours painting those Darkness and Demons figurines. Just all day in my parents' basement, in the dark, painting, vitamin deficient. Good times. Seems like only yesterday.
That was like 3 days ago.
Yeah, hold on a sec. Hey, is that pocket done? I like it scalding hot in the center. All right, where was I? Oh yeah, labs. All those clots forming, am I right? So expect to see clot breakdown products as well. These are called fibrin degradation products and include D-dimer, symbolized by the D&D Dungeon Master Guide, raised in the air. And if measured, which we rarely do, low levels of protein C and antithrombin. So to sum it up, PT and PTT are up because of a loss of factors, D-dimer is up because of all the clots, and bleeding time is up because you've consumed all your platelets. Everything else is down, all of your clotting factors, including protein C and S. I'm talking everything. Even other molecules that participate in the clotting process that you might not think of, like fibrinogen and antithrombin. And don't forget about platelets, down as well. I'm telling you, it's the whole ball of wax. On peripheral blood smear, you may just find a few schistocytes, which are fragmented red blood cells caused by mechanical damage to the cell membrane. In this case, by the shearing force encountered as red blood cells try to squeeze through small arteries full of fibrin clots. Oh, don't worry about the pizza. My mon, my man is going to get us some more. Yeah, my boy, man, boyfriend. All right, with all this madness going on, how exactly are you supposed to treat DIC? By far, the most important therapeutic intervention is to treat the underlying condition that kicked it all off in the first place. Beyond that, the key to treating DIC and preventing further damage is careful monitoring of the patient, most importantly for signs of bleeding. If a patient is bleeding, there are several things to do. First, fresh frozen plasma may be given to replace the coagulation factors, von Willebrand factor, and protein C. If fibrinogen is low, cryoprecipitate may be transfused to raise those levels. Thrombocytopenia? Give platelets. Anemia? Give RBCs. You get the picture. Treatment of thrombosis, on the other hand, is much more complicated. Because overdo it on the anticoagulation and you've got an even more terrible bleeding disorder on your hands. Heparin may be used, but monitoring it is tough. In short, disseminated intravascular coagulopathy sucks. And it's a slow process. Depending on the underlying etiology, mortality can be as high as 40 to 80%, and that's in the best case. Furthermore, even once the underlying cause is resolved, it takes the liver and bone marrow several days to clear all the byproducts, synthesize new ones, and return to a normal state, if they make it through. All right, let's shift gears here. DIC is caused by the massive consumption of coagulation factors, but there are other conditions that prevent their synthesis to begin with, one of which is vitamin K deficiency. Before we talk about missing vitamin K, though, let's look at its normal role in the body. There are several clotting factors that are dependent on vitamin K for their function, all of which were covered in our warfarin sketch in Sketchy Farm. In fact, we've brought back that whole scene on game consoles everywhere. It's
Kill corpse. Contemplate the complexities of modern warfare and the difficulty soldiers often have when reverting to civilian life after experiencing extreme combat situations. In 4K and 60 frames per second. New modes include first person and shooting.
just like in our warfarin sketch. This game features the vitamin K dependent factors 2, 7, 9, and 10. Factor 2 is thrombin, represented by the Throm Beaver Brigade. Factor 7, the 7 Deadly Sins Brigade. Factor 9 for the 9 Lives Brigade. And last but not least, Factor 10, the Fox 10 Brigade. If you look closely, you can just make out protein C and S in the back, which also require vitamin K. That's C for captain and S for sergeant. Vitamin K is usually synthesized by colonic bacteria from precursors found in green leafy vegetables and oils like olive and soybean oil, the perfect snack for poning noobs. Once formed, vitamin K is activated by the liver enzyme epoxide reductase, abbreviated VKOR. So in front of the TV is a liver-shaped console, VKOR, powering those K-shaped controllers. Once activated, vitamin K acts as a cofactor for gamma-glutamyl carboxylase, which allows all of the vitamin K-dependent factors to do their thing. That's why, if you look back at the screen, the medic is putting gamma bandages on the coagulation factors, so they can keep fighting. That's gamma for gamma carboxylation. Check out the warfarin sketch for more details about the function of vitamin K. For the remainder of this sketch, we're going to illustrate what happens when you subtract vitamin K from this whole equation. Vitamin K deficiency is most commonly seen in infants for several reasons. First, vitamin K doesn't cross the placenta. Second, newborn GI tracts don't have the intestinal flora that synthesize vitamin K. Third, there's very little vitamin K in breast milk. And lastly, the newborn liver does not effectively utilize the vitamin K that babies do get. So good luck figuring out that controller, kid. Combined, all of these factors lead to a potentially life-threatening vitamin K deficiency in newborns, aptly named hemorrhagic disease of the newborn, which consists of intracranial hemorrhage, retroperitoneal bleeding, and even death. Infants are routinely given a vitamin K injection shortly after birth to make sure they have enough until their gut bacteria start making enough. However, if a newborn doesn't get that exogenous vitamin K, such as in a home birth, or if mom refuses to let her child receive the injection, he or she can develop severe vitamin K deficiency that can lead to intracranial hemorrhage, retroperitoneal bleeding, and even death. Vitamin K deficiency is much less common in adults, but when it happens, it's usually secondary to another process. Diseases such as chronic pancreatitis and inflammatory bowel disease cause malabsorption, which can lead to low levels of vitamin K. Antibiotics also kill the helpful bacteria in our gut and can cause a transient vitamin K deficiency. Chronic alcoholism and cirrhosis also impair vitamin K activation by epoxide reductase in the liver, in addition to disrupting the synthesis of the coagulation factors themselves. Any of these conditions can lead to deficiency in adults, which would typically only cause symptoms when the deficiency is severe. In adults, if vitamin K deficiency leads to bleeding, it's usually mild and presents as easy bruising, epistaxis, or prolonged bleeding after injury. And because this is the more coagulopathic type of bleeding, rather than the platelet type, keep more severe GI and genitourinary bleeding on your radar, though this is more rare. On laboratory assessment, vitamin K deficiency has a more pronounced impact on the extrinsic pathway due to reduced factor 7, leading to a prolonged PT, symbolized as always by our PT paratrooper, extrinsically entering the scene. APTT, on the other hand, is most often normal due to the modest activity of factor 9. If vitamin K deficient patients present with clinically significant bleeding, they can be treated quickly with a transfusion of fresh frozen plasma, represented by FFP fighter jets. FFP contains all the vitamin K dependent factors you could ever want, already modified by vitamin K and ready to work. Mild bleeding symptoms can be treated with vitamin K supplementation directly. Gotta always have extra controllers on hand. All right, almost bedtime. So let's sum this thing up. Disseminated intravascular coagulation, or DIC, consumes everything. Coagulation factors, platelets, red blood cells, most of my weekends, in full major tire. Yeah, I don't get out much. DIC is usually kicked off by a major illness. the most common being gram-negative sepsis. Though malignancy, trauma, nephrotic syndrome, and pregnancy complications can all crash the party as well. The massive activation of the coagulation system, combined with the massive consumption of its components, leads to a vicious cycle of both bleeding and clotting, with bleeding predominating. Look for ecmoses, mucosal bleeding, and general oozing from anywhere in the body. Though bleeding predominates, it is possible to form DVT, PE, and even arterial thromboses. Since pretty much everything is shot, there will be an elevated PT, PTT, bleeding time, and D-dimer, along with thrombocytopenia, anemia, and schistocytes on peripheral smear. Treatment? Replace the missing components, treat the underlying condition, and cross your fingers. Much more benign, for the most part, is vitamin K deficiency. Vitamin K is synthesized by colonic bacteria, activated by V-core in the liver, and teams up with gamma-glutamyl carboxylase to activate clotting factors 2, 7, 9, and 10. Highlighted up on the screen there. Newborns are prone to vitamin K deficiency because it doesn't cross the placenta. Their GI flora have weak game, and there's no vitamin K in boob juice. A hit of vitamin K shortly after birth can prevent intracranial hemorrhage. So look forward to no sleep, hours of shrieking crying, a mountain of used diapers, and a healthy baby. Adults, on the other hand, usually don't have enough vitamin K due to malabsorption disorders, as in the case of chronic pancreatitis, IBD, or antibiotics wiping out gut flora. Cirrhosis leaves patients with too little epoxide reductase activity to produce enough vitamin K. Luckily, severe hemorrhage is rare, though possible, and treatment is vitamin K replacement, or, if urgent, fresh frozen plasma. Me, though? All I need is some fresh frozen pizza. Some dice, my imagination, my trusty dice case, a basement. Like, one where Lady Longshanks can be whoever she wants to be without the man trying to tell her who she... Should probably get out more. Next on our coagulation disorders journey. Instead of bleeding, get ready for some clotting.